Mr. Umbdenstock's career includes experience in major health system administration. He's been a true leader. He has not only done it, he has written about it and thought about it. He's been also an expert in HMO governance. He's written several books around hospital boards and governance, and has been very involved with some of the survey work of the Health Research and Education Trust and the like. He's on the National Quality Forum Board of Directors, a National Priority Partnership, and chairs the Hospital Quality Alliance. And I can say that he has been in my own only 8 months on the job, he has been a great ally at NAPH on the issues, and we've been working together fabulously. I'll also introduce our second panelist before I turn it over to Rich. Our second panelist will be Alan Weil, who's Executive Director of the National Academy of State Health Policy. He's been in that position for about 7 years. They're a nonpartisan, nonprofit organization that seeks to help states achieve excellence in health policy and practice. Alan directed the Assessing the New Federalism Project at the Urban Institute. Before that, he served in Colorado as a cabinet officer who oversaw the Medicaid and medically indigent programs. He's had a variety of top-flight roles and has been on the Commonwealth Fund Commission on a high-performing health system. He has just also joined and returned to the board of the National Public Health and Hospital Institute, so we're really thrilled to have him. And there's perhaps no one who is better versed in what's happening on the state level. So first, let me turn to Rich.
Thank you, Bruce. Good morning. Let me be the 14th person to welcome you to Chicago. This you may not know, some of them I'm sure you do know. This is the corporate home of the American Hospital Association. Has been for, I'm guessing, I have to go back and check my history, but probably about 90 years. And a vast majority of our staff continue to work and serve you out of Chicago. So welcome. I too want to again say congratulations on your 30th anniversary. Congratulations to Larry. And welcome to Bruce. And as Bruce said, we enjoy a terrific working relationship and look forward to building on that. It wasn't mentioned as part of the introduction, but I spent 27 years in a very non-urban area called Spokane, Washington. I actually had a lot more connection with the rural health delivery system than the urban public health system, although Spokane has no public hospital. So our large medical center, teaching center there, was in effect the public enterprise. But I'm proud to say that tonight my wife joins our oldest child as she graduates from her residency at the University of Washington, and a lot of that time at Harborview, which certainly is a vital public institution and referral center in that part of our country. But also, I would personalize this a little bit because in our family, we have a family member who is homeless, who has not worked for his adult life, who has come to depend totally on an urban health system. And we've seen up close and personal just the incredibly important role that the members in this room today play in helping those who, through whatever reason, have nowhere else to go. And so we're trying to do our best to support from afar, but couldn't be done without the kind of systems in this room. So I may not have lived it directly, but certainly have experienced it in a very close and personal way, and I thank you for that. Now, it goes without saying that things are changing, and they will continue to change. But I want to start with where I want to end, and that is to suggest to you that we know exactly where healthcare is headed. Kind of a bold statement, but I believe it. I'll give you three things very briefly. More integrated, more at risk, more accountable. That's the summation at the end of this brief set of comments. I'll come back to that. More integrated, more at risk, more accountable. So where do we find ourselves politically and economically at the moment? Well, you know as well, or I'm sure probably even better than I, the fiscal environment in which our layers of government find themselves today, and in particular at the state level, As a matter of fact, just to share with you a little secret, it's pretty hard from the AHA at the national level to try to get members engaged in what's going on in D.C. because you're so riveted in what's going on in your state capitals. It was true during the health reform debate, no criticism. It's true now, no criticism. It's just so large and so imminent that it's really, really important, especially to our public hospital members. So that's not surprising, but you know what's happening to the finances there. You know the implications of the end of the additional FMAP support, and you know the gut-wrenching decisions that your legislatures are going through at the moment. At the federal level, nonetheless, there's an awful lot going on, and I know you're well aware of it. In the short term, in a time frame sense, the government's trying to deal with this issue about the debt limit. It's a stop sign. It's forcing some action by, we're told, August the 2nd. In the longer term, and that's going to lead to some programmatic kinds of changes. It makes us vulnerable in some of the immediate senses of programmatic changes, funding changes, and so on. In the longer term, they're focused on the issue of the ongoing deficit and how to tame that programmatically, and that gets you to the issue of entitlement reform. Talk about that in a second, but that's where we take a direct and long-term hit because of the way some of these proposals have been structured. Politically, we know that historically it's been easier to go after Medicaid than after Medicare, but I'm not entirely sure that's the same today, or certainly that it will be tomorrow, because of the number of people previously thought about as being in the middle class who are now dependent upon these public programs after years of economic downturn, high unemployment, and so on. And of course, the number of seniors who are now dual eligibles, who, if not themselves, who traditionally vote, that's why Medicare is more difficult to hit, but now their families who are supporting them and seeing this are starting to get, again, a more firsthand and personal experience. So I don't know if the politics there are changing or not. Maybe I'm being a little optimistic, but I think it has to have some effect. Now, the Biden Commission has been the place where everybody has been focused in Washington as to what's going to happen, what's going to take shape, and so on. And you know from this morning's headlines that they hit a major speed bump yesterday when Mr. Cantor decided not to go to yesterday's session because he objected to the Democrats' emphasis on raising revenues or taxes. Apparently, Mr. Kyle wasn't going to come back either. So things are now either at a standstill, a showdown, maybe best case a cooling off period, who knows. But some of the commentators are noting that maybe it's the right thing. Maybe you need to boost this up to the people who are going to make these final choices anyway, the President, the Leader of the Senate, Mr. Boehner in the House, and so on. So we'll see what the impact of that is. But we know that major issues are on the table, from GME and IME to Medicare bad debt payments, the whole issue of Medicaid provider taxes, maintenance of effort, a long list of items that have been mentioned as possible targets, certainly some of those programmatic changes in the short run, and that's a problem. Now, what we've been trying to do is stake out a position in Washington on behalf of the hospitals and in particular the communities and patients that you serve in a couple of different ways. First of all, just this week, we released the study that had been commissioned by the AHA, the AMA, and AARP, trying to put a real face to the cuts that are being discussed under some of these proposals that would arbitrarily cap entitlement spending. One such proposal, we don't think it's the one that's moving forward. We don't think that this is the only one. We weren't trying to single it out, but we picked the CAP Act sponsored by Senators Corker and McCaskill and asked Lewin and Associates To quantify for us, what would this mean? Well, the way in which this particular bill is structured, the more a program grows, and once it hits that trigger point, the more it's grown, proportionately the more it's cut. You know where that takes you. It takes you right to Social Security, Medicare, and Medicaid. So although it doesn't say it directly, that's both the intent and the impact. Lewin's findings. Such an approach would reduce federal spending by $4.2 trillion from 2013 to 2021. About 860 of that would come from Medicare, 575 billion from Medicaid, about 704 billion from hospitals, although some will point out, and the study did point out, that this will drive cost shifting, obviously. So you'll get back some of that to the extent you can cost shift onto a commercial population, to the extent you have a commercial population on which to cost shift. So let's look at it from that point of view, because it's not good news for the privately insured or the commercial insurers. It would result in and of itself, an additional 5% increase in private insurance over that period of time. More troubling, even more troubling, 3.8 million people would be forced into the poverty levels, and 5.1 million would lose coverage. So definitely some severe impacts, definitely moving things in the wrong direction. Trying to put a face on it, trying to help people understand the direct impact, trying to put it in human terms. In the more immediate realm, we've been working together with NAPH, AAMC, Federation of American Hospitals, the psychiatric systems, and others on an ad campaign inside the Beltway the past several weeks, and continuing under the theme of enough is enough. In that regard, we're trying to get through to lawmakers that hospitals have stood tall, were a major part of supporting extended coverage through foregone increases in payment in the future, and want to see that maintained, and don't want to see additional cuts put on hospitals. Don't think that's right, and we'll talk about some of the alternatives we're proposing. But we're kind of laying down the groundwork with both of these important messaging campaigns to say we are reinventing ourselves as we go. We want to see other sectors called upon to do the same. We think there are alternatives to these kinds of blunt cuts and arbitrary triggers, and that hospitals are in no position, again, given the increasing age, the increasing needs and vulnerabilities of our patient populations, to take on more reductions. Importantly, we've scheduled an advocacy day. If you're able to make it, it would be terrific. It's July the 13th in sunny, cool Washington, D.C. Unfortunately, we don't schedule these things by weather, but we really do need a strong showing to carry this message up onto the Hill. Now, just to close out, a couple of thoughts about what we need to be pressing if we're not in favor of these kinds of arbitrary cut mechanisms, cuts and triggers and cuts. One is in terms of the opportunities to try to manage or reduce Medicaid spending. Frankly, we think that public officials ought to look to the Affordable Care Act and the provisions there for two reasons. One is that they need to work across both programs, but the other is we don't need different answers in different programs that make it impossible for us to manage. But looking at it from the patient and public point of view, we do think that there's long-term promise in payment system and delivery system redesign, broadly called accountable care. We're starting down that road with a lot of collaboratives across the country with the private sector. We hope the ACO regs get rewritten to encourage it in the Medicare sector, and we want to see that build out in the Medicaid system as well. Bundled payments, something that we're very anxious to see where CMS is going to head with that. And we're told that although the program won't start soon, we may start to see some trial efforts in that regard. Don't know what to expect, but we'll wait and see. And value-based purchasing, pay for performance, things like that. We ought to be building out those systems in a very focused and coordinated way across all of our programs. Certainly we can do more to coordinate the care of the dual eligibles and others with chronic conditions, increase the use and reduce the drug costs through generics, look at the restructuring of co-payments, although I know that's very difficult in the Medicaid population. Maybe more cost and administration than you actually collect, so we've got to be careful about that. And take a look at long-term care and the types of tax incentives we might need to encourage more individual participation, again, to the extent people can do it. Now, looking forward, as a last set of comments, I want to end where I started, which is we know where this is headed. We just don't know the exact drivers or the exact mechanisms, but more integrated, more at risk, more accountable. We see it all the time, hospital-to-hospital collaboration. You heard it in the prior panel, hospital-to-community collaboration, certainly hospital-to-physician collaboration. As an anecdote, we believe that there are more physicians employed by hospitals today than there are members of their national trade group. I mean, it's just amazing how the hospital-physician integration phenomenon is starting. And we're working with a lot of the specialty associations, societies that are growing in their membership and that are more and more hospital-based, hospital-connected to try to drive collaborative efforts at the national level. More at risk, non-payment for never events, non-payment for readmissions. We know where this is headed. We will be either fixed in the amount we're paid per episode, per procedure, maybe someday per person. We know that we will receive payment on a more narrow list of interventions and procedures, and the risk is shifting to us. We have to then shift to an even higher gear of cost management, partnerships and care coordination, and prevention. And lastly, more accountable. That is very clear. Everything we do now is going public. That will be even more so. People want that information. And frankly, we've learned how to use that information and drive our own improvement efforts. So I used to get complaints from my members about the demand for public reporting. Today I get complaints that we're not turning around the data fast enough for you to use it real time in your improvement efforts. So you can tell the transformational shift that's gone on there. So we've got a lot of work, but I'm very positive that we know the tracks we're on. We don't know exactly how this political game of chicken, if you want to call it that, will play out. We do know that we will be paid less and will be paid less often in terms of the types of procedures we do. One caution I would offer, many members say we have to do more with less. I would challenge you to think about doing less with less. We actually have to figure out where to get the biggest impact, and it might be on the preventive side long term. But doing more and expecting different results isn't the answer. We have to be much more efficient, parsimonious, but push those outcomes forward. And already the hospital field is showing terrific progress in the safety and quality realms, and I know we can do it in the financial realm. Look forward to working together on that, and again, certainly continuing an outstanding partnership with NAPH. Thanks very much.
Good morning. In lieu of slides, I've asked that the lyrics to popular songs scroll along the screen as a tribute to the NAPH staff who last night, not against my will, but certainly against my better judgment, convinced me to go to a karaoke bar after the event. I hope my presentation today doesn't suffer too much for that poor judgment of mine. I am going to try in very short order to give you a little picture of the state of state implementation of the Affordable Care Act and health transformation more broadly, and it's of course impossible to do it justice, and in most instances you know the situation in your state far better than anything I can tell you, but hopefully I can frame 5 areas of thinking for your planning and your activities in the coming years. So the first point I want to make is that states are very actively engaged in implementation of the Affordable Care Act. It is true that at the end of this year's legislative sessions, only about a dozen states will have signed legislation to set up insurance exchanges. It is true that half the states are suing the federal government, but do not be misled. The lack of legislative process at the state level is in many respects a reflection of tension between the executive and legislative branch. Many state legislators were elected in this last cycle running against the Affordable Care Act. Many governors are in a position of trying to figure out where their state is going to be in 2014 and beyond. And it's much easier for a legislator, we see this at the national level all the time, it's much easier for legislators to just say no and be obstructionist for ideological reasons than it is for executive branch leaders who actually have to run things to stand aside under the threat that the federal government will come in and play a major role in implementing the law if the state fails to act. And so the legislative progress is not a fair proxy for where states are in implementation. Similarly, people I hear criticizing states as being hypocritical in suing to block the law while they're also pursuing implementation, but in fact, it simply reflects 2 different roles that governors and attorneys general have. At one level, they're political leaders and they are arguing for their case. At the other level, they are the executive branch leadership accountable for results, and they know that they have a strategy that may or may not succeed in trying to get the law thrown out, and so they have to plan for both eventualities. So although it is easy to look at the degree of opposition, I can tell you that all but a couple of states are very actively engaged in figuring out what this law means at the state level, in pursuing implementation one step at a time, some with more enthusiasm than others, I won't deny it, some with some approaches that are potentially more the kind you might prefer, and some with not such an approach, but I don't want you to come away, which is easy to do looking at the popular press, with the impression that the opposition to the law that does exist in much of the country translates into inactivity. In fact, state implementation of the law is very much underway. That's the first point. The second, and I don't need to tell you this, but it is worth, I think, reinforcing, is that these are really tough times for states. And it's not just that total budget shortfalls in the current fiscal year, depending on when you do the math, are in excess of $100 billion. It's not just that the maintenance of effort provisions in Medicaid take away the option of states to reduce eligibility, which is not something they do happily, but without that, it leaves them really with only one tool, which is rate cuts. But it's that you have 29 new governors who came into office the exact year that the federal enhanced FMAP is phasing out. And between 2011 and 2012, states will be hit with an additional $60 billion in aggregate in Medicaid costs, which is more than total state revenue increases in a good year, and this is not a good year. And what these governors don't know, because they're new, is that actually state spending on Medicaid in last year was lower than it was 2 years earlier because of that stimulus funding. But they weren't in office. So they see a 15% growth in state expenditures on Medicaid, and they think this is the way it always has been and the way it always will be. And part of your job and our job is to educate states about the reality of the situation, which is this is not a program out of control, eating all other spending. This is a particularly bad year, but I will have to say it comes after a couple of bad years and going into some other bad years. So this may be the worst, but it's not that we're out of the woods. So states and governors and the political process at the state level is really struggling right now in a unique way and in a way that you, I hope, can help educate about a longer-term trajectory. The third point, again, one you know, but I want to emphasize, is that we really are in a unique time with respect to the notion that everything is about the budget at the state and the federal level. And I have to say, I was in Colorado working for Governor Romer, who was at the time the chair of the National Governors Association, chair of the Democratic Governors Association, when we were fighting Medicaid block grants in the early 90s. That was a little bit a budget issue, but it was mostly an ideological issue. And now there's plenty of ideology to go around, don't get me wrong, but the budget frames every single discussion. And what it's done is it has created political language that I've really never heard before, because I see analysis everywhere about the human costs of cuts. And it's just not working, because what's being said is, well, we just can't afford it. We know people will be hurt, but we can't afford it. So Pennsylvania, the adult basic health program, gone. Tens of thousands of people uninsured. Washington Basic Health shrunk to its smallest size in over a decade. A waiting list in excess of 100,000 people. One of the most popular programs in the state. But there's just this sense that we don't have enough money to do things we know we need to do. And so the discussion can't just be people will get hurt or this is a bad choice, because that line isn't working anymore. Too many people believe we just don't have the money. We're broke. We can't do this. And so we're going to make decisions that hurt people, and we're okay with that. We're not happy about it. But it's creating a very different kind of discussion than I've heard before, and frankly, it means that strategies about priorities have to change. The fourth item I would like to bring to your attention is the importance of your attention at the state level on implementation issues of the Affordable Care Act that go beyond the core issues that you often focus on, like DISH, which is, of course, a state and federal issue, and others like it. And I just want to make sure these are on your attention list, because they will have tremendous implications for you, but you may not be a part of these conversations if you don't intentionally insert yourself into them. One area that states are working on a tremendous amount right now is improving their eligibility and enrollment systems. They have to do this because of changes in Medicaid eligibility standards and determining eligibility for income-based subsidies for people entering the insurance exchanges. This is administrative, bureaucratic stuff that doesn't make it into the papers, but it affects whether or not the patients in your hospitals have coverage, and whether they have continuous coverage, and whether that continuous coverage, in thinking about accountability, it's only with continuity that you can actually have a population you can work with and be accountable for results. You have a tremendous stake in your state and often county systems improving their eligibility and enrollment systems. And this is a tremendous opportunity right now for states to do this. I would encourage you to pay attention to it and advocate for it. Second is the issue of interaction between the exchange and Medicaid. You have been so heavily reliant upon Medicaid as a source of funding and serving the uninsured. We now have this new exchange that's going to potentially cover tens of millions of people with incomes just slightly above the incomes of the people that you're accustomed to serving. And that creates all kinds of questions about who are the carriers going to be in that exchange? What's their delivery system going to be? What are their networks going to be? Are commercial plans going to try to reach down and cover your population? Are the Medicaid-only private plans, the Centenes of the world, going to try to reach up into the exchange? The whole market in which you operate is shifting, and the relative roles and the interactions between the exchange and Medicaid, those decisions will have a tremendous effect on the population that you serve. And a third area is benefit design. There's a lot of attention, of course, to the essential benefits package, which will be federally defined. But states have critical roles around benefit design. The Medicaid benchmark package, which is the benefits that the newly eligible Medicaid folks will get, that will be up to state level. States have mandated benefits, and they will have contracting provisions within Medicaid and the exchange that will affect what benefits people have. And you all know that a growing share of the burden that you confront is people with underinsurance who come to you when they have uncovered services or they have high deductibles. Take a close look at what the real benefit design is going to be in the insurance exchange. Those are going to be high deductible plans. There are going to be a lot of very moderate income people who move into suddenly they have health insurance, and they're going to have a lot of out-of-pocket costs before they see any benefit, and they may still come to you. So how the benefits end up being designed in this program at the state and national level are going to have tremendous implications for you. So don't just focus on the funding flows, DSH and Medicaid eligibility. Keep your eyes on eligibility enrollment systems, the interaction between the exchange and Medicaid, and benefit design. And the final point I would make, and I guess all of these should go without saying, but I spend my life running around the country saying things that should go without saying, is that we have there is a new vision of coverage in the Affordable Care Act. It's a vision. It's a vision of continuous subsidy availability from 0 to 400% of poverty, regardless of family structure, something we've never had in Medicaid. We certainly haven't had family-based federal tax credits at the higher level. It's a vision of continuity. It's a vision of near universality. Once you start thinking about the population 0 to 400%, Medicaid is a part of that, but it's only a part of it. And so our vision of Medicaid is going to have to change. Just yesterday, I was in Washington at the meeting of the Kaiser Commission on Medicaid and the Uninsured. Everything we're thinking about Medicaid now has to be looked at through the lens of a context of a broader population, not just a targeted Medicaid population. And if Medicaid has to change, then the safety net has to change because you're so intimately tied to that program. So if we're going to achieve this broader vision, we're going to have to do it in the context of rethinking the program that you're most reliant upon. And you can't avoid it. And it raises questions like, what are the appropriate levels of cost sharing? We've tended to protect the Medicaid population, but now it's got to be seen in the continuum of a broader cohort that goes much higher up into the income scale where we know that cost sharing is going to have to play a significant role. So I just want to close with this thought. It's one I try to include in every talk I give because we spend all this time talking about financing and all this time talking about the challenges we confront. Now, I am not a clinician, but I spend a lot of time on the Commonwealth Commission and other places with those who repeatedly remind me and have convinced me with data that we operate in a healthcare system with, give or take, 30% clinical waste, 30%. This is a grossly wasteful system. And it's that waste that's giving Americans the false impression that we don't have any money. It's why we think we can't afford Medicare and Medicaid. It's why workers aren't getting raises, because we keep shoveling money into this wasteful system. And it used to be that that was a bad thing, that waste should be driven out because waste is bad. But as we are now cutting people off of programs, debating and discussing, decimating the safety net, the core protections that low and moderate income Americans have, we really have to confront the fact that failure to squeeze out that waste is a life or death decision for people. If we don't bring this system down to a more efficient production model, we are killing people because we are taking away the money we need to meet their basic needs. Now, you're going to talk in the next session about delivery system change. You heard terrific models going on in the session right before ours, and I want you and need you, and you know you have to embrace change within your own systems. But I would encourage you as you struggle, and I know how big the struggles are now, to look inside and to deal with the changes in the system around you, to also keep your attention more broadly, because there are forces that are resistant to the kinds of change necessary to drive that waste out. And the further along we go towards the vision and the endpoint that Rich described, the more vociferously those interests will object to change because they're living off that waste. That's their livelihood. But that livelihood pales in comparison in importance to the true life or death difference that coverage and services make to the populations that you serve. And at the end of the day, this is going to be a battle between a wasteful healthcare system and making the tough choices that people will oppose, or a health system that actually meets the needs of the people you serve. And so you have to not look inside, but also be part of the broader discussion so that we can keep moving on the policies that will help drive the waste out of the overall system, so that we aren't making these terrible choices and decisions about how many people to cut off insurance, but we're actually redirecting the efficiencies that we know are possible in the system towards the missions that you all have. You have to keep an eye on that, or else we're never going to make our way out of the situation that we're currently in. Thank you.
Thank you for two great presentations, and I want to, before we take questions, just give an example in a totally different field of what Alan was talking about. Yesterday I was with my daughter, and she wanted to get a new book, and she has her Kindle. And so, several years ago I would have gotten in the car, driven to the mall, bought a book for $16, driven home, used a fair amount of gas in the whole thing, and the bookstore would have done well. Yesterday, we pulled out her Kindle, searched for what she wanted, downloaded it, totally frictionless, efficient, cost $8, and guess what? Amazon is incredibly profitable, and Borders is in bankruptcy. So it gives you an example. And yes, and sometimes it's waste, and waste also can mean a real radical restructuring of the world around us, as we're seeing currently. So we have time for questions now, and I thought I would please get ready and queue them up, but I'll start with the first question to our panelists. Recently in Washington, there's been talk of this almost apocryphal McKinsey report, which projected much quicker erosion of employers offering insurance, much higher numbers of uninsured going forward, created a lot of consternation for folks. And, there's been a lot back and forth. The methodology has been very criticized, et cetera. But notwithstanding that, we also heard yesterday from Uwe Reinhardt the same message in some ways. You're not going to have 22 million uninsured. You're going to have 35 million or maybe more. And so my question to the panelists is, what's your sense of what we're actually going to be facing in the out years under the Affordable Care Act? A lot of the things in there, like reduction in dish funding, were predicated upon large drops in number of uninsured. Will that actually be realized, you think, or could we be looking at a very different picture? Now, either one of you first.
Well, I wasn't here for Uwe's presentation, so I don't know where he came up with his number.
I guess came out of the atmosphere,
That's
basically.
Good.
Yeah,
he has good atmospherics, so it's good. I am nervous. And I think the McKinsey report is a bit of a sideshow, as we are so good at sideshows in Washington. But, I worked, my organization is the unofficial home for the nation's CHIP directors. CHIP is a fabulous program, but it took years to get people to enroll their kids in a very low-cost program with, in general, very good benefits. The notion that somehow we're going to, on January 1st, a federal holiday, 2014, convince 14 million or 16 million Americans to sign up for something that, frankly, if you look at the Kaiser data, a quarter of Americans think the law has been repealed. So, you know, the notion that we're sort of suddenly going to convince them that this is the product of their dreams, and then all these employers are going to say, oh, thank God I don't have to do this anymore, seems truly ridiculous to me. I think we are going to see, and this is pulled out of the air, I think we're going to see much slower enrollment in the exchanges than people expect. That's even assuming the subsidy levels stay the same, and I think there's going to be tremendous budgetary pressure to ratchet them down before 2014. But even under current law, people don't, we work in this field. Normal people don't know when a new government program starts up. This program has to be sold, and high deductibles, limited benefits. Many people are going to be surprised at this. This is not the GM health insurance policy. So I think it's going to be slow to sell, slower than we think. And I think, therefore, the notion that employers will be able to say to their employees, oh, you'll be fine over there. That's a great program. And the employer's going to be saying, what program are you talking about? So it's hard for me to look long term, but when I think of the first few years after 2014, I would expect exchange enrollment to grow much more slowly than the budget estimates.
Rich?
Yeah, I would agree. I think I'm in the same place as Alan's general comments, or generally in the same place as Alan's specific comments, sorry. The notion that it's just going to be easy to just flip your employees into some public realm, I think is foolish. It didn't happen, hasn't happened yet in Massachusetts. Yeah, the penalties are too low, and we know why they're too low. They wouldn't have gotten the votes they needed to get the bill passed in the first place. So, you know, they're trying to keep it under the magical $1 trillion. Not that $1 trillion isn't a real number, but it was a political calculation. Now, in Massachusetts as well, they said, you know, geez, we better do something about this. And if it's going to stay this way, then the government's now faced with a different decision, which is to either watch the private insured sector disappear or do something about the design of this program going forward. To Alan's point about this not being a terrific coverage, I think it's going to be very clear, especially to those who maybe have somebody looking out for their interests and knows something about this and can help them understand the impact. But you know, people understand today that more, both the consumer and the provider understand that more consumer copay or cost sharing is a very risky proposition. People haven't had a raise in well over a decade in real income. Savings rates have been nowhere. Self-pay, from our point of view, effectively, is no pay. And so it's not going to be quite as neat, simple as people project. I think Alan's exactly right. This is going to be a very tough sell to get people to enroll, even if they are qualified. We've been noodling around, frankly, trying to figure out how we can support getting people enrolled in this new program. We, the private sector, certainly hospitals, you know, if we could magically put a kiosk in each hospital and be the facilitator, it'd be great. But we've got to get way upstream from that and get people enrolled. That's going to be a huge undertaking. And we know, of course, that you know even if the bill rolled out as planned, there's still 25 or so million people that aren't going to be covered anyway. So anything that falls short in the bill is just going to add to that. So I think we're going to have this burden for a long time.
We have time for one or two questions from the audience. Anybody? Yep, you have one right over here. I think it's Erica.
Alan, I really appreciated your comments about the sentiment of the general public saying, and government saying, well, we just can't afford it. And it sounds like a logical strategy is to focus on waste. But beyond that, what can we do? It's awfully depressing, and knowing that this room is filled with people who are not in it for the money and really in it to help low-income, vulnerable populations. How can we continue to do what we're doing, and what strategies would you recommend given that sentiment?
I like the easy questions. You know, You have experience, for example, out of Los Angeles with the county population willing to tax itself because of a sense of ownership. And I go back to the incredible presentations before ours, which are, of course, incredible also. But this is about community ownership. And you are the National Association of Public Hospitals. And what is lost in the current debate is that there actually is a difference between public and private. No disrespect to, we're a nonprofit, I run a private organization as well, but public is different. Public has built-in accountability, which creates a level of community ownership that is available, but not always realized, let's be clear, and you should all look inside your souls and figure out whether or not you've been able to cross some of those boundaries. But I have always been struck that the success in actually generating political will for revenue comes from people feeling connected to the product that they're being asked to pay for. And there is little connection closer than the one that you all have built in to your design. And then the question is whether or not to use it. Now, I will be the first to say that doesn't necessarily help you at the national level and may not even help you at the state level. And I don't think, in my heart of hearts, I don't think the solution here is a county-by-county financing system. That's not what I'm saying. But I think you need to build off of the sense of community asset, community resource, community accountability, public accountability, leading the efforts of transparency, leading the efforts of ties to the community so that people have an increased sense of value. I know that's a little glib, but I just don't know any other way out of this than to remind people of the value and that they own it, which is something people seem to forget in Washington.
Rich, do you want to add to that at all? Or?
You know, I'd just go back to the prior topic and panel and add one comment to Alan's answer, which is we've got to think more collaboratively. If there is only so much to go around and we're talking about all treating the same people or touching the same people in the same area, we've got to do it much more efficiently. In my experience, before I took this job, I was involved in a highly collaborative enterprise. Just to prove it, we had 38 hospitals on one IT system. You think that's easy. But I'm here to tell you that what you already know, which is collaboration is a lot harder than competition. Competition is pretty easy. I do my thing, you do your thing, we both go home feeling well. Somebody pays the bill. Somebody pays both bills. We've got to figure out how to collaborate more at the community level and stretch these dollars and think about that one person, that customer, call it what you want, that we all work together to help treat. But if it's all about me and my plan and so on, well, I'll be honest, I'll challenge us as hospitals only. Think about all of the strategic plans in this room and all of the plans for growth. Please add them up. Please tell me if we can afford it. The answer is no. Now multiply that across other entities in the community. So it's time for a reality check.
Thank you so much. Another round for our panelists, please. And if we could have our next panel come on up. Need a fourth chair. And we're going to need a fourth chair as well. That was great. With the ending note. So our next panel is going to now take us down really to what some of our members are actually doing in the post-reform or ongoing reform landscape. And we're delighted to have really 4 experts with us today to lead that. Moderating today, one of those folks will be Barbara Iman. Many of you know Barbara very well. She is a partner in the Ropes and Gray Healthcare Group. She is one of the national health law experts on financing and policy and care to the underserved. She works with us. She works with many of our members on very important national and local issues. She has done a lot of work also as well, not just in Medicaid, but in the Children's Health Insurance Program, on Medicare, on a number of other things. And she's been really a great advocate in many ways for the things that we do, because we rely immensely on her as well as other folks there for their intimate knowledge of safety net financing. So with that said, let me turn it over to Barbara.
Can you hear me? Yeah, it's on. Well, I thank all of you for hanging in there and staying till the bitter end, the very last session of our 2011 conference. And I think you'll find it worthwhile and be glad that you did. The idea of this session really is to take all of the building blocks that we've heard about over the last couple of days. We've had sessions on high-cost patients, on readmissions, on patient safety, on, for those of you who got up at 7:30 in the morning this morning, safety net financing and 340B on partnerships. And really, these are the folks sitting here with me whose job it is to really sift through all of that, pull all of that together, and bring it up on a macro level, prioritize, strategize, decide where the efforts are going to go, and really lead their organizations into the future, which, as Rich Umbdenstock so well put it, really is a future of accountability, integration, and risk. And I think most of you would agree with that. And so just, how are you all going to do it? So we're kind of moving up to the senior leadership level from the building blocks. We're not going to have PowerPoints. We are not going to have prepared presentations. It's really designed to be more of a free-flowing conversation among the panelists. And I'm going to monopolize the mic with questions for the first part of it, but I will certainly leave some time for you all to jump in towards the end. So our panelists today, Art Gianelli is president and CEO since June of 2006, I understand, of New Health in Nassau County, the Nassau County Healthcare Corporation, formerly. And he worked his way up through actually the county system and had previously had county budget and finance responsibility before coming in and leading the organization. Despite the advertisement, this is in fact not Kate Walsh sitting to Art's right. And unfortunately, Kate was sick this morning, so Tom Traylor, who many of you know and whose precise title I'm not sure of, but Jack of all trades, I think, sure. for Boston Medical Center. And Tom, thank you very much for pinch hitting on short notice this morning. And Wright Lassiter at the end is the CEO of Alameda County Medical Center, has been in that position since September of 2005, and previous to that was at another NAPH organization in Fort Worth, Texas, the JPS Health Network, so certainly has long and extensive safety net experience. So thank you to all of you for participating. And I thought that just to kind of orient us, maybe we just start off and go down the line and just very briefly describe to us your health systems, what you're composed of, your patients, your community, whatever you think is important for us to know to put into context your comments. So.
Sure. Well, again, I want to echo Barbara's comments. Thank you, everybody, for staying right to the bitter end. I did this panel at the last national conference, and it's a testament to your dedication, and it's appreciated by the panelists, obviously. My name is Arthur Gianelli. I'm the president and CEO of the New Health System, formerly the Nassau Healthcare Corporation. We're about a $550 million concern. We run the Nassau University Medical Center, which is a safety net teaching hospital. the A. Holly Patterson Extended Care Facility, which is a nursing home, and through a public entity model, we cooperate a series of health centers with the Long Island Federally Qualified Health Center. We're a part owner of a health insurance plan. We have about 3,800 employees, 24,000 admissions, 250 to 300,000 ambulatory visits. Nassau County is in the top 1% of all counties in the United States in terms of per capita income. So you don't often associate Nassau County with the need, frankly, to be providing safety net services. But nevertheless, despite the affluence of much of the population in Nassau, there are significant pockets of absolute and relative poverty in Nassau, concentrated in a series of zip codes that we are the primary provider of care for. Our population is ethnically mixed, significant African American, Hispanic, South Asian, and other populations. It's a very complicated market within which to operate because there's significant hospital penetration and great competition for the commercially insured and Medicare patients.
Good morning, and I'm happy to pinch hit for Kate this morning. My name is Tom Traylor, and I've been at Boston Medical Center, our predecessor organizations, for 30 years, so I know the system very well. The main hospital, we have about 500 beds, an academic medical center in Boston, a very competitive hospital town. The hospital's budget is about $1 billion. We do 30,000 admissions, 600,000 ambulatory visits, 130,000 emergency room visits. In addition to the hospital, we have a large Medicaid health plan, which I actually run. It's 250,000 members. Its revenue is $1.2 billion. And it's Medicaid under healthcare reform, the Commonwealth Care Program, so it's all low-income members, and that's throughout the state of Massachusetts. We have a network of 15 FQHCs that are affiliated with the hospital and is largely the referral network of Boston Medical Center in our neighborhoods. Massachusetts, we've obviously been through healthcare reform, so we're thinking about this a lot as it relates to not just 2014, but where we already are. 5 years now after Massachusetts healthcare reform has positioned, so I'll be happy to work that into the questions as they come out, but we are living the healthcare reform piece and getting prepared for the payment reform piece, and they're two different pieces, so look forward to the interchange.
Good morning, I'm Wright Lassiter, and as Barbara said, I'm the CEO of Alameda County Medical Center, where I've been for about 6 years. Alameda County Medical Center is about a $550 million operation, so similar in size to ART's organization. We're comprised of 3 hospitals, Med-Surg trauma facility that sits in Oakland, California, a freestanding psychiatric facility that's about 80 beds, about 12 miles away, and 150 plus bed subacute SNF and acute rehab facility. We also operate several FQHCs, both in East Oakland and in bedroom communities, sort of south and east of Oakland. We're an interesting organization. We are a public organization. We exist sort of uniquely in the state of California in that we're the only organization that's not a department of a county. We're a separate corporate structure. We're what's called a public health authority in the state of California, and we exist as the only public hospital that has that structure. And so we have a fiduciary board of trustees appointed by county board of supervisors that have the fiduciary responsibility for our organization, and that's a unique structure in California compared to other public hospitals. And we've had that structure for about 13 years, since 1998. In terms of size of our operation, we're fairly similar to New Health in size and scope, in that we have about 25,000 admissions. Next year, we will see about 330,000 ambulatory visits. We have a pretty busy emergency department in our main facility that takes care of 80+ thousand emergency visits on an annual basis, and our psych hospital sees about 11 or 12,000 folks in its psychiatric emergency department as well. We operate in a market that's very, very mature, and I see my my friend and colleague Winston sitting there. It's very mature in that Kaiser has dominated the market from a commercial perspective for many, many years, having 50+% of the employed market. Sutter Health, another not as advanced as Kaiser, but a reasonably integrated system, comprises the rest of the commercial market, about 30-some-odd%. And so our organization has a typical payer mix of a safety net organization: 55% Medicaid, about 13 to 14% Medicare, about 6% commercial, and 18% what we consider county indigent care. So those are folks that are under 200% of poverty, where our county has committed to ensuring that they have health care, and so we provide health care for those individuals. We have extensive partnerships with our federally qualified health center network in our community, and so fortunately we take our small ambulatory network and combine it with 8 community clinic corporations that have 30 sites around the county of Alameda. We have a pretty robust safety net structure. And so I guess the last thing I would simply say before we get into this in terms of context is that California attempts to be on the leading edge of healthcare, and while we weren't quite as far out as Massachusetts was with health care reform, our state has a fairly innovative and unique Section 1115 Medicaid waiver that the state calls our bridge to reform, that we are currently implementing and have been implementing that for about 9 months now. And it will provide some significant ability for public hospitals in our state, I think, to continue to transform ourselves so that we're prepared for a reformed healthcare environment. And I'll certainly talk a little more about some of the strategies we're trying to do as we get into the discussion.
Thank you, everybody. So with the healthcare system changing as rapidly as it is, and with new ideas and new models and new systems coming up daily, you come to a conference like this, you hear about all this great work that your peers are doing. I'm sure if you had 48 hours in a day to spend on preparing your system for the future, it wouldn't be enough. So how do you work through all of that noise and sort of figure out what your priorities are? What are your priorities? How has your system come to decide on what its priorities are? And I guess I didn't want to ask this question, but if you want to answer it in this way, what is it that's keeping you up at night? So, I'm going to start at the other end and ask you to start.
Okay. Well, at the risk of breaking the rules around having too many priorities, I'll share a few things. Happily, nothing's really keeping me up at night. I don't get a ton of sleep, so I try not to let too much keep me up at night. But some of the things that we're focusing on, I would think, are probably not much different than what many of you are focusing on. It's to start with patient experience. I think Alan talked a bit about everyone wanting to be middle class, and so the notion of how do you diversify your payer mix. And so clearly patient experience is something that's really important. And so we spend a lot of our time trying to demonstrate the value proposition that the experience coming to a public hospital isn't inferior to the experience of coming to a private hospital. And that's important to us. We're spending a lot of time on harm reduction. Our board set a goal of a 50% reduction in harm across our health system about a year ago. And that was an 18-month target. And so we're rapidly moving towards that goal, and then expect to set another goal to reduce harm that much more thereafter. So quality and safety, very important. Access, something that we're spending a lot of time on. Most of us don't have enough capacity to deal with the access issues that are expected of us. And certainly as we talk about having patients choose us when they have a choice, or having patients in the exchange choose our health systems, we have to be able to have physicians that have capacity to see them in a timely fashion. So we're spending a lot of time on access. And frankly, one of our biggest priorities this coming fiscal year is how do we build more ambulatory access so our wait times are acceptable. Cost reduction, I think we're all focusing on looking at our reimbursement drying up, or supplemental revenues drying up, or doing less, using Rich's comments from the last session. instead of doing more with less, doing less with less. And so how do you rationalize the services you provide, and how do you reduce costs in a meaningful way? We have focused, since I've been there, on the notion that we're not going to cut costs on the backs of staff, and so we don't go through the process of trying to have massive layoffs as the way that we solve our cost issues. That doesn't mean that if we have inefficiencies, we don't try to deal with them. But we're focusing on cost reduction and looking at things that a lot of private hospitals look at, Medicare margins, and trying to understand, how Medicare-like margins impact us and whether we can survive on that. Given that we're in California, where we deal with a lot of Medicaid margins, and in the state of California, Medicaid it's a big gap between Medicare and Medicaid. We obviously want to focus on Medicaid margins also. So cost reduction is a big issue. And then last major priority for us is partnerships, both internal and external. So internal partnerships around our medical staff, and how do we create more alignment and integration with our medical staff. Outside the organization, looking at something that I think, Alan, I think you might have mentioned this earlier, and that is, how do you start to have relationships with private physicians that you haven't had in the past, and does that make sense? And how do you do that in a way that doesn't completely spook your medical staff, who says to you, wait a minute, we've been committed here forever, and now you want to talk to those folks down there that have never been committed. So how do you do that? And then also looking at other private partnerships. We're actually working with a local health system and trying to acquire one of their facilities to expand our footprint. And frankly, one of the things that I find is that public-private partnerships are much easier within the health system. They're much harder in sometimes convincing the community that makes sense. And so that's a whole different topic for a different day. But external partnerships are probably the last priority I'd mention for us.
My first thought, Barbara, when you mentioned the priorities, was Larry's matrix with whatever 26 or 8 cells, and all of the competing priorities. And of course, all of those things need to be addressed. But at a higher context, I would say the hospital, we're looking at a couple of things. One, we're still reacting and trying to work out of the financial situation that happened to us because of healthcare reform. We're making some progress on that, but sort of that's live and in front. And we're still trying to reach financial stability, even while we prepare for the next level in Massachusetts, which they're calling Healthcare Reform 2, or the payment reform piece. So in both regards, our strategy is to be proactive, both at the state level and with CMS around, in the Medicaid waiver, in the case of CMS, to help correct some of the math that was fundamentally flawed in the thinking around, in Massachusetts, we could take all the DISH money, the monies we had for a statewide free care pool, we'll just use that for coverage, and we don't really need, the hospitals don't need that any longer because people are covered. So of course, that doesn't work, as you well understand. We're making some progress, but we need to address that, and we continue to address that. In getting prepared for the future, we're doing a couple of things. On the partnership side, we are tightening up our internal partnerships. As I mentioned, the system, we have a large health plan. We are bringing some of the skill sets from the health plan towards the hospital, looking at a period in the time of the future where the hospital will be responsible for more risk at our own patients. Our health plan is statewide. The hospital's volume is concentrated 60-70% within Boston itself. But there is an overlap, and we're trying to bring that skill set to the hospital to help them prepare to take on the risks that are coming. In addition, we have our own physicians that are in 22 faculty practice plans. We're having discussions about the level of subsidization from the hospital to the faculty practice plan to help them with their payer mix, and how sustainable is that given the financial crisis. Our network of health centers, we're working with them to how to get ready to be an ACO or to collectively take on risk for our shared members or patients in the Boston network. So we're tightening that up. Outside our existing system, we're looking at some of the other DISH hospitals in Massachusetts, which we affectionately call the baby DISH hospitals, and to work with them. Could we get a DISH network eventually where we take on the risk? We have the infrastructure with the health plan, and being by far the largest hospital, as we move forward, being the tertiary hospital for their community hospitals. And then on the payment reform itself, we're trying to work with the state about where this bill is going. it's our view we can actually impact how the design is. It's pretty wide open. You might have read the governor of Massachusetts has proposed a bill that's sort of an outline, but the details are yet to be worked out. But the state has been pretty aggressive that it wants to move completely away from fee-for-service to a accountable care organization within 5 years or so. But how that works is completely open. So we're working legislatively to do that. One example is around the commercial rates. It's interesting, you might have saw some coverage. The Attorney General has been issuing reports around the disparity in rates for the same activities, and it's all transparent, listed by procedure, by hospital, that the big privates get twice as much as the DISH hospitals or some of the community hospitals, and that's getting a lot of exposure. In the latest report, one of the state agencies put out, they made a comment that if we reduce the top provider rates by 20% and we increase the bottom rates by 20%, the system would still save something like $300 million. So that, in my mind, is an example of the legislation. Will there be corridors? Will there be legislated amounts to help the have-nots, if you will, with the commercial rates as the system moves forward? There's been many comments about if we move away from fee-for-service to a global payment, but if we lock in the competitive advantage of the more dominant systems, then you're never going to get the savings out. So that's something we're working with as it moves forward. On the cost side, we've done a lot of work in the financial crisis we found ourselves in the last couple of years, and we worked with FTI, who I think is here at a targeted program looking to take 5% out of our $1 billion hospital budget, and we are largely there, $50 to $70 million over 2 to 3 years, and that has been critical and very helpful. It didn't solve our problem because our funding was reduced by, on a total basis, about 20%. So, and then we've received some of the money back in the waiver, so we're down to about a 5% problem still remaining from the existing, movement around taking the DISH money to cover. But we continue to look at cost and to sort of demonstrate where they are, bringing the external folks in to benchmark. We have found helpful. We're working with the state government a little bit more collaboratively. We did sue them in this process along the way, so that caused a little tension. But we're trying to get on the right page as it moves forward.
Okay, from the perspective of the new health system, we have sort of a three-pronged vision. Number one, to be a high-quality, low-cost provider in the region, dedicated to the triple aim. The triple aim, as I think many of you know, is to manage the care of the population that you serve, to enhance the experience of care that population has, and to do so in a way that begins to bend the cost curve. Number two is to either be or more likely be part of an integrated care delivery model. That's a major initiative of the National Association of Public Hospitals, the emphasis on integrated care delivery systems. We believe that's a necessary condition in order to be successful in however health reform actually is implemented. And third, to develop a sustainable, self-supporting business model. By self-supporting, I simply mean a recognition that there aren't going to be additional subsidies for the care that we provide from our local county government, which is in its regular financial collapse, which is what happens every so often with our county, despite the affluence of the population. So there's got to be recognition that they're just not going to be of any help, and that we need to forge a strategy and a structure that permits us to be able to survive without any infusion of funds for operating purposes. Just some specific initiatives that we've been working on. We put a heavy emphasis, as Wright and Tom have indicated, on quality. We take the position that we expect nothing less than excellence in the provision of care, and we've made dramatic movement in core measure compliance. We've begun to see reductions in mortality due to heart failure, AMI. We have seen significant benefits to our efforts to reduce hospital-acquired infections, and we've done a lot to make more robust our primary care, various primary care quality initiatives. We are looking to expand our primary care base. We're a typical academic medical center. We have heavily specialized services. We need far more primary care physicians. On the one hand, we're benefited by the fact that we have an employed physician model, which is going to be very helpful in the context of reform. But on the other hand, we've got to do more to attract more primary care physicians and connect with community physicians who provide primary care. We have a number of strategies that we're undertaking there, mainly leveraging our federally qualified health center status to be able to expand into other areas. I'm going to talk about that, particularly as it relates to mental health. We are undertaking a rather aggressive managed care strategy. 18% of our admitted volume is commercially insured, yet 6% of our revenue comes from commercial payers. I've used the NAPH database. We rank last in the NAPH database. We have we have the wonderful designation of ranking last amongst the NAPH hospitals in terms of commercial revenue per discharge. If we were simply paid Medicare by our commercial payers, it would be an additional $14 million to the bottom line. If we were simply paid what Bellevue Hospital, which is not exactly a bastion of commercially insured patients, but probably has a very similar payer mix to ours, it would be an additional $30 million to the bottom line. There is a lot of work that we have to do. It's a very competitive commercially insured market, though. So we've taken the sort of the unprecedented stance of actually basically issuing a letter to every one of our commercial insurers and telling them we're putting you on notice that we will go out of network. We are intent on negotiating, but take seriously the threat that we will go out of network. And for us, it's more of a threat to the insurance companies than to us because we don't see a lot of elective volume. It's a lot of volume through the emergency department, and we have some ability to be able to maneuver. The initial response by the insurance companies, frankly, have been far more solicitous than I thought they would be. So we may be able to gain some traction there and gain some traction relatively quickly. We've been benefited by a number of a state program, the Heal New York program, as well as county tobacco securitization revenue that was made available to us to modernize our facilities. We've used that to modernize a number of our floors, build a new emergency department, implement health information technology. We have 85 acres of real estate that can be redeveloped. We partnered with an organization called Healthcare REIT, Real Estate Investment Trust, to help us to structure a series of joint ventures for the development of the property, consistent with the operation of the hospital and the nursing home. And we're doing a lot to align our develop physician alignment strategies and to revamp our faculty practice plan, which is a productivity-based model, and incorporate a number of the other things that I think we need to incorporate, such as a number of quality indicators, utilization metrics, et cetera. And last, there's been a lot of discussion, fits and starts. I'm sort of a little bit ahead of my board on this, so I'm not sure that I'm going to really get there. But I do think that there needs to be a reorganization strategy relative to our hospital. I had proposed as an initial step a strategy of clinical integration with the major not-for-profit system in the area. And if done correctly, and if connected in with the fact that under our statute we have state action antitrust immunity, it's my view that we can actually be able to incorporate ourselves or piggyback on their ability to negotiate with the managed care companies. So, you know, if we could do some initial work to get our managed care rates up to something reasonable, and then make that next step in terms of clinical integration with the major system in the area, I think it could be materially to our financial benefit, and certainly to our benefit in terms of the quality of care that we're providing to the patients that we serve.
Wow, making my head spin listening to all of that. But there's lots of themes there for us to pick up on, and I'd like to try to do some of them. And Tom, maybe one of the themes that you all raised was primary care and partnerships with local providers as a way to expand your primary care base. Tom, you know, you've had the coverage expansion, you've had healthcare reform come. You know, we've heard about primary care shortages in Massachusetts. you know, you can partner with local entities and to provide primary care, but are you experiencing an actual shortage of primary care, and just sort of shifting the building blocks around, you know, does that actually expand primary care access? And what, if not, what do you do about that?
Well, a couple of comments. We don't have a particular shortage in the healthcare reform in Massachusetts. Really has occurred over 20 years as opposed to the last 5. So even though we've had volume growth over the last 5 years, we're largely treating the same patients we did before. Formerly, they were uninsured. Many now are on Medicaid, or in Massachusetts, what they call Commonwealth care. Those patients had complete access in our system even while they were uninsured. So from that, it's not different. But we are looking at, and we have a partnership program with the 15 community health centers. So we have joint hire programs where the physicians work at the health centers and at Boston Medical Center. And I think that's helped with the recruitment in sort of getting enough primary care physicians for our network. We do have one initiative we started looking at with a venture firm, a private firm called Rise Health, and they're looking at helping us redesign primary care in the hospital, in a pilot of 40 primary care physicians in the Department of Medicine. We hope to expand that later to the health centers, where they're looking at a comprehensive overview of taking the traditional academic medical center model and breaking in its parts, so that the physicians do, you know, just what the physicians need to do in partnering with others, adding resources, a call center, getting the sort of the registration information, all of that out of the front. So really organize it in a more efficient way, and we're hopeful that that will be both economically beneficial to us in the plan. They would, you know, we have goals of bringing the no-show rates down considerably, to shortening the length of the visits themselves so we can get more throughput through. At the time, our faculty practice plan has worked towards agreeing to take the number of visits per session up from around 8 or 9 up to eventually 11 or 12. So we believe that we'll have more capacity and the patients will come through. And then in the end, the folks in the practice talk about it being putting some fun back in primary care and getting some of the, you know, non-physician clinical stuff out of the way of the physicians and nurses to smooth things out. So this is envisioned to happen over 3 years. The state is excited about this pilot. We've actually introduced it a little bit to CMS in some of our proposals. So that's the major initiative we have in primary care.
Okay, thanks. Art, you mentioned behavioral health, and I know that your organization is undertaking some initiatives in that area. I wonder if you could tell us about those initiatives, and in particular efforts to integrate behavioral health and primary care. And if either of you two would like to comment, we don't need to have everybody commenting on everyone, but if you want to add, feel free. So.
Oh, that's a great question. As many of you are, I mean, we have a significant inpatient psychiatric service for both basic psychiatry, adult and children's psychiatry, chemical dependency, et cetera. What is very clear, though, is that there is not a connection within our community between our hospital, our federally qualified health center, and a number of the mental health providers, the mental health clinics, if you would, within Nassau and Suffolk County on Long Island. There is both a care and a business opportunity here. The care opportunity is this. Many patients go to these mental health organizations simply to get their meds for their psychiatric conditions. They are not getting primary care. And as a result of not getting primary care, these mental health patients die far too early, lead lives with multiple comorbidities, and are inadequately served by the health system on Long Island. The business opportunity is that these mental health providers are being cut rather dramatically by the state of New York. Where we can come in is in 2 ways. One, we can provide doctors to these mental health organizations to provide the primary care co-located with the provision of mental health services, and we can do it through the extension of our federally qualified health center. We're going to get a rate of about $210 a visit through our federally qualified health center, which is an extraordinary rate, and it beats any kind of rate that any other organization can get for the provision of care to this population. So the general strategy, we've begun by creating what we call the Long Island Primary Care Behavioral Health Network. And it's going to be a network of mental health organizations and our hospital and our federally qualified health center. And the theory, or the strategy is going to be to leverage our federally qualified health center to either incorporate the mental health organizations into the federally qualified health center or co-locate or expand the health center into these mental health facilities. That's the strategy in order to be able to bill, but the care strategy is to co-locate primary care and behavioral health and to bring the primary care doctors where the mental health patients are going to seek their current psychiatric care and obtain their meds. The other benefit to the state, quite frankly, and into the community at large, is that we, through the FQHC model, have the ability to be able to provide access to low-cost prescription drugs to the 340B program. Our partner is Walgreens, as one of the sponsors here for NAPH. So I think it's a robust model connecting mental health organizations, our hospital, our federally qualified health center, and access to low-cost pharmaceuticals through Walgreens, bringing primary care and co-locating primary care in the mental health organizations, going to where the patients go to receive their care. We think that's good care. We think in the end that's actually going to be good business as well.
Barbara, I would just say that we're taking a similar approach, but we're sort of approaching it from the other direction, which is we are working through what's called a low-income health plan that's focusing on individuals 200% and below, and we are trying to co-locate mental health services within our existing FQHCs, and so it's the same strategy. It's just approaching from the other direction, and principally attempting to use a strategy of LCSWs to provide a lot of that care and to offer to our primary care physicians an opportunity that for those patients that they're managing that have other mental health, behavioral health issues, that we can provide that service right there in the place where the patient's already coming. In Alameda County, there are many benefits, as I mentioned early on, to our structure being independent from the county. But one of the disadvantages, frankly, is that we have always been involved in the inpatient service, and the county has had some responsibility for the ambulatory activity. And so there isn't much integration, and there isn't much service being provided on the behavioral health side for ambulatory behavioral health services. And so under this new low-income health plan, we're going to be able to finally integrate within both our FQHCs and our community-based FQHCs mental health services so that our patients will receive both services in the same location.
Right back to you again. I want to actually pick up on Alavilas's comment this morning about the middle-class view of public hospitals and talk with you or anybody else about communication strategies that you may be undertaking to try to project and your value to the community, and overcome any perceptions that may be lingering, misperceptions, should I say.
So we're undergoing a lot of the priorities that I mentioned early on are sort of under the rubric of our ACMC 2020 plan, where we're really trying to evaluate how do we over the next decade, and some of these are short-term strategies, some are medium-term strategies, how do we reposition our organization so that we stay true to our mission, but we expand our attractiveness to patients who might not have traditionally sought us out, or patients who will have opportunities in the middle part of this decade for other providers. So one of the steps that we took was to undergo a community perception study and bring in a PR, community relations firm to do a lot of interviewing of the community, both folks who had used us and those who had not ever used us, to get perspectives about our level of care, our service, the perception of would you seek care, and if so, why or why not? If you have sought care, if you had different choices in a few years, would that change? And we learned some pretty interesting things. We clearly learned what our strengths were in terms of, we clearly learned that the ambulatory network was our strongest product offering for our community by far. We also learned, though, that there are, as most of us know, there are real complicating factors with the perception of your trauma service and how that impacts elective care. We have a facility where for many years the front door has been coming in fairly adjacent to our emergency department. And so a lot of the community says, well, you don't go there unless you have trauma, right? You don't go there unless you're the victim of a automobile accident. You don't go there unless you're a gunshot victim. I mean, so we have some of those perceptions, which many of us may have if we operate urban trauma facilities in the middle of cities. And we actually thought that our psychiatric service might also be a negative halo on our system. And so we were sort of thinking through how do we begin branding our system as we talk about our med-surg services, our preventive services, our ambulatory and specialty services, and our psychiatric services. And one of the things we found was that, no, people respect your psychiatric service, they respect your emergency intervention and your inpatient service, but they're really worried about all that trauma stuff coming from the main hospital down to that suburban psych hospital. And so if you want them to send some of their voluntary psych patients, they're really worried about the quote-unquote, they're not concerned about the quote-unquote crazies, they're concerned about the gunshot victims or the other folks coming down from the quote-unquote county hospital. So we are in the midst of a fairly complicated strategy session trying to work through with our board and our senior leaders. How do we begin to retell our story? How do we associate the positive parts of the community perception, being principally our ambulatory network? How do we continue to say to people, trauma is important and trauma is a lot of what we do, but it is a small, tiny sliver of our business. 2,500 trauma cases a year. That's all we do. When you think about 300,000+ ambulatory visits, trauma sort of pales in comparison, but that's all people see. So we will begin about a 12-month rebranding process internally where we will focus on name, and we're sort of taking sort of the Procter & Gamble approach to our community branding, which is we're trying to look at every one of our operating divisions as an entity with value to the community, because that's what the community has said. We value your ambulatory network, so tell us more about your preventive and community health networks as a separate standalone, not necessarily tied to your system, not necessarily tied to your med-surg trauma hospital, but as an ambulatory community health offering. Tell us more about your mental health services, packages mental health services, not just as the inpatient psych hospital, but all the things you do, all of the outpatient psychiatric services, the substance abuse services, all the things you do beyond just your psych emergency department. So we will begin rebranding our psych division in that manner. We'll begin rebranding our acute rehab hospital, which has a lot of community appeal outside of the uninsured and outside of the lowest sector of the community. We'll begin rebranding that in a fairly competitive way because we're trying to position our rehab hospital as a regional referral center for the community. And so we will begin sort of rebranding ourselves in this sort of Procter & Gamble mode, the House of Brands concept. And what will also come with that very likely is a name change with our system. What we also heard was that having county as the second word in your name doesn't help you. And that's probably not a surprise for a lot of people. And some of you have county in your name, some of you don't. We have New Health, which, there's no sense of county in the name, or you have, New York Health and Hospital Corporation. Well, it's implicit as to what you do, but the name county isn't there. So I think the biggest thing that we're learning is that we have to be smarter about marketing and public reception, public relations in a way that we haven't been in the past. Our organization has spent zero effort branding ourselves in the community. We have sort of felt that the good things that we do ought to be good enough, and in this kind of competitive environment, it's certainly not. So we're taking, an internal approach for about the first year so that everyone in our organization understands who we are, what we want to say to the community. and then we will begin to sort of unveil outside the organization after about 12 to 16 months with some new branding approaches.
Okay. Any of the other one?
I have actually a couple of thoughts on that. We've actually undertaken a lot of what Wright is describing. We did a very similar market analysis, and it revealed a couple of things. It revealed, number one, that it was going to be very hard to move people's perceptions of the public hospital. There were long-standing perceptions. You know, you go there for emergency care, you go for trauma, you go for psych. You know, you don't go there for elective. You get transferred to the private hospitals, et cetera. And that you need like the Nike marketing budget to be able to move the dial on that. But what they said to us was very interesting, and Wright actually hit on this. See, we're not just our hospital. We're a hospital, we're our ambulatory network, we're our nursing home. And we had a corporate name. The corporate name at the time was the Nassau Healthcare Corporation, and no one knew what that was. So when that was pulled, everybody was like, what is that? So our marketing firm came back and said, your opportunity is actually to call that something else and treat that like an empty vessel. In other words, the corporate name has no community identifications with it. Start making some. So we've started to emphasize the corporate component as opposed to the individual components of the system. So that's what we came up with. We did a whole branding exercise, involved a lot of our leadership. We tested it with the community. We came up with New Health. And that we've started to brand prominently inside our organizations, in our signage, on our website, in how we communicate to the public. Now, I'll tell you, I go to things and people are like, well, what is New Health, and what is, aren't you a hospital? Or then they mix the two up, and, it becomes one long convoluted term that's not right. And that's okay, because it's an opportunity for me to explain what it is that we were trying to do. But in our messaging right now and in our branding, we lead with New Health, and we were actually confident enough in that. I don't know if you're going to be able to see this, but this is actually our annual report. And if you see on the bottom, it doesn't say anywhere on the cover Nassau University Medical Center. It only says New Health. And we took a shot with that because we said, we want people to start using that phrase, that term, in their description of us. What we then have done is a few other things. Number one, we've done an advertising campaign utilizing New Health and leveraging things that we do new. So we just opened up a new emergency department, and we did a whole television advertising campaign around that. We opened up new programs or services. We do that as well to emphasize the new component. And even again in the annual report, what I try to do is speak to certainly what people would think about in terms of a public hospital, emergency services, trauma services, et cetera, but then use it as an opportunity to put in all sorts of interesting things about physical medicine rehabilitation and obstetrics and bariatrics and orthopedics and things that you'd come to by choice or more electively than normally. One of the other tricks that we've used is that I try to get I don't have a huge marketing budget, just like what Wright's describing. So I try to target on a cheaper basis two groups. One is what I call the chattering class, and these are the people that talk to everybody in the neighborhood or in the county, and they're on a blast email list, and they get at least an email a day or every other day from us about something that's going on. And some people read that extensively. Some people just look at the headline, but they at least know something is happening, and they identify something positive with what it is that we're doing. And the second group that I try to target, and actually I get a number of people who come up to me and reference those emails, and that costs me precisely nothing to do. And the second thing is that we're trying in a number of different ways to communicate more directly with doctors, to poll doctors in terms of their perceptions, what they need, and to really go above and beyond to satisfy the needs of the community physicians, because if we can get them to see us as being easier to use, as we're getting better OR time, things like that, then those are the kinds of things that reverberate back into the community of physicians and hopefully draw some patients in.
And I have a whole lot more questions, but I'm just going to ask one before opening it up to you all, which is somewhat self-serving, but what can NAPH do to help you all in what you're trying to do? And whoever wants to take the first crack at that.
I'll start. So I think I'm excited about the Transformation Center, and I think working directly with CMS, you know, a little bit frustrated. They seem stuck in their regulations and looking at sort of overly at the Medicare side versus Medicaid. So I think working with them to try to get them over this hump, and that Medicaid is different. I mean, we've had many conversations with them. We're trying to get them to understand and in some ways help them get a win in where they're stuck in rolling this out in the Innovation Center. So I think that's a great start, but sort of just staying with it and being persistent, I think we'll get there. They're slow, they're bureaucratic. It doesn't feel to a lot of us too innovative yet, but hopefully they'll get there. So I think continuing along those lines would be helpful. And I think beyond just sort of helping, you know, educate them, even though theoretically we're on the same side around the Affordable Care Act and where we want to go, I think they need help. There's still a big learning curve for them. So to figure out as many ways as possible to work with them to have in the safety net system how critical we are for successful implementation of healthcare reform. You know, we bring to them the Massachusetts experience, but still they're seemingly still overwhelmed by what's in front of them. So I think just working with them around that would be one big way you could help.
I would just echo the Transformation Center. You know, at ACMC, we're trying to do the same thing. We're creating what we're calling our System Transformation Center that will serve as a hub of innovation, spread, and kind of internal consulting. And so I think the ability of NAPH, I think NAPH members have to accelerate our collective and individual improvement efforts. And so the ability for NAPH to create viral spread of that, I think, is really important, along with what you do with Washington. So,
I agree with everybody said. I think NAPH is precisely in the right direction. I'm particularly pleased with the amount of information we've received from NAPH, the seminars, the webinars, the briefs that we get. They've been much more prolific even in the last year, obviously thanks to Bruce's leadership. And the Transformation Center, we're obviously looking forward to that as well.
Okay, good. Thank you. Any questions from out there? And I guess we're not going to have any questions from out there. I'm sorry. We're going to close up now and get you all out to your airplanes on time. So I apologize. I did intend to let you get. I just wanted to keep asking. So Bruce, I understand you're going to close us out, and thank you very much to all the panelists for sharing your insights.
Thank you to our panelists, and we're looking forward to engaging with you on all these issues and transformation. I have to say, this is the first panel I have been to, I think, in about at least 9 months or 8 months I've been here, where I don't think anybody mentioned the term ACO. So I don't know if that's indicative or something. I don't know. Yeah, interesting. So anyway, well, thank you so much, and thank you all for having been here with us these last few days, whether you're members, some of you are in the fellowship program, or other friends. I also want to thank the staff who put this meeting together. I especially want to recognize Anika and Pam and Betsy. And I know there are many others as well. I also want to just remind you that we have our fall conference and clinician legislative event coming up September 19th through 21st. And there we'll have, I think, a great program, but the focus will be on bringing clinicians from your organizations to Washington to join us in the advocacy efforts on behalf of the safety net. Also, next year, our annual conference, June 20th through 22nd in San Francisco. I think I'm going to send the slide up. June 20th through 22nd in San Francisco will be our next conference, our annual conference, so we look forward to seeing you there as well. So thank you so much for having joined us. Please give us back your evaluations, and we wish you a safe trip back to your home and loved ones.